It's Friday, the 6th of December, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. Neal Tucker here as usual. And yes, the big news today is it's 19 days till Christmas. Are you feeling festive yet? No, probably not. And the bad news, I'm afraid, is that the three pieces of research that we've got to talk about today are probably not going to help you get in that festive mood either. But the good news is they are really interesting. So we've got a paper in the BMJ on whether chocolate can reduce your chance of developing type 2 diabetes. If ever there was a good news story, this might be it. Then we've got a paper from the New England Journal of Medicine on whether you can do a blood test to check your cardiovascular risk in 30 years' time. Is that feasible? And then we're going to round up with a BJGP paper. And this current BJGP edition is really interesting, all about vulnerable people. That's the theme. Lots to have a look at here, and there's a great bit of qualitative work on deep end GPs talking about their motivation and challenges and insights working with some of the most deprived and difficult populations. But we're going to have a look at a paper on digitalized primary care in the UK, a qualitative study of the experiences of minoritized ethnic communities. So is modern day access to general practice helping or hindering some of our populations? A quick bit of NB news first. So we are all done for live courses this year. They'll be back in January, kicking off with our Hot Topics Dermatology in Primary Care course. Do check that out. But don't forget, you can watch all of our courses on demand. So if you've missed, let's say, our brand new updated diabetes course that ran last weekend, then you can go back and take a look at that at your leisure. And of course, it's even better to do that with NB Plus, our subscription service, where you can access all of our courses live or on demand, and loads more in the website too. Straight into the research then today, and let's kick off with this BMJ paper. So, good news, chocolate may help prevent type 2 diabetes. Sounds too good to be true? Yeah, that's what I thought as well. To be clear, this is observational data from 3 cohorts of US nurses, followed up over around 30 years or so. So this can only ever be called or classed as an association. And the bad news is that it's only dark chocolate, the worst of all the chocolates. I know that statement's going to upset some people. You'll probably be emailing in, but I'm going to stand by it. Initially, I thought that perhaps the benefits were simply because no one wants to eat much dark chocolate. So it's not like you're smashing back a couple of Mars bars or something. But the authors are selling up on the idea of flavonoids, which apparently are plentiful, particularly in dark chocolate, and they have antioxidant, anti-inflammatory, and vasodilatory properties, all of which might mean they can reduce your chance of type 2 diabetes through various cardiometabolic benefits. So what did the researchers do? Well, they looked at 192,000 US nurses, followed up from around 1986, who have been sent periodic questionnaires, so every 4 years or so. I should point out that this is not a gigantic study lasting 40 years or so to simply examine whether we should be eating more chocolate. They were collecting loads and loads of data on this group, and this is one part of it. But some genius back then clearly thought it would be useful to ask, amongst all those other many questions, what about chocolate? In the initial data, they were asking simply about total chocolate consumption. And then in 2006, someone thought, hang on a second, maybe we should ask about the type of chocolate that they're having as well. Is it dark chocolate? Is it milk chocolate? They weren't getting into the real nuances like, have you had a bag of Maltesers or just chowed down on a Snickers? Some patients in this cohort were excluded from this analysis, primarily if they already had type 2 diabetes, but also if they had a history of cardiovascular disease and cancer. They also looked at a whole range of different variables so that they could adjust for confounding. To give you an idea about the study population characteristics, the mean age at inclusion was 52 and 80% were women, which is unsurprising given the fact that we're following nurses from the mid-80s. So the key results were that almost 19,000 of that group developed type 2 diabetes over the course of follow-up. And after adjusting for things like personal, lifestyle, dietary risk factors, the data showed that people consuming 5 or more portions of chocolate per week, that sounds like quite a lot of chocolate. I couldn't actually find out where they clarified what a portion was, but that sounds like quite a lot of chocolate to me. They found that that group had a 10% lower chance of developing type 2 diabetes. Now, this seems to be down to dark chocolate consumption, because actually if you just looked at that group rather than total chocolate consumption, they had a 21% reduction in type 2 diabetes rates. Meanwhile, they found no such association in those just eating milk chocolate. What they did find was that group demonstrated some weight gain. Now, I have to say, I am quite incredulous at these results. Is it really feasible that eating dairy milk, which I love, by the way, the best of all the chocolates, can make you gain weight but doesn't increase your risk of diabetes? Are flavonoids, which they talk a lot about in the paper, so potent that the amount found in dairy milk or Galaxy or the cheap stuff in Aldi that you can get which tastes gross and I've given up on, is it feasible that the amount of flavonoids in these chocolates are sufficient to provide this almost magical effect on the body? And is it feasible that dark chocolate, which admittedly will have a lower sugar content, be of net benefit to our bodies? Could it be that despite the author's best efforts for controlling for confounders, that there are other factors at play here? I am simply speculating, but they do report that people who eat dark chocolate are also more likely to have a generally healthier lifestyle. Nevertheless, maybe I need to park my incredulity because in the discussion, the authors cite numerous studies suggesting benefit of dark chocolate. Although it's fair to say that the vast majority of that data is also observational in nature. And so really, I don't know that it increases our confidence that much. Ultimately, the authors conclude that dark chocolate intake may be associated with a lower risk of type 2 diabetes, and they call for randomized controlled trials amongst middle-aged participants and for longer durations to clarify what's going on. I'm in. Sign me up. Okay, next we've got a really interesting paper in the New England Journal of Medicine. A bit of background about why I thought this was so interesting. Last year, if you were on the Hot Topics course, you may remember us talking about cardiovascular risk modification and the role of LDL as a marker of future risk, including the possibility of using it to consider a person's lifetime risk. One of the limitations of cardiovascular risk tools like Q-Risk is that they look only at the next 10 years, and in younger patients, age results in low scores over that period and doesn't necessarily indicate when a person might be at significantly raised long-term risk. This group, it suggested, and this is a notion that I personally buy into, might benefit from earlier intervention, be that lifestyle or drug, before atherosclerosis develops. This study then is titled Inflammation, Cholesterol, Lipoprotein A, and 30-Year Cardiovascular Outcomes in Women. This is another very forward-thinking piece of research. So the researchers followed 28,000 healthy women in the US, also healthcare professionals, but a different cohort from the BMJ study. And they measured high-sensitivity CRP, LDL, and lipoprotein A in all of them. I didn't even know that they had high sensitivity CRP back then. I thought this was quite a new thing, but it turns out in the research setting, maybe you could get it ages ago. And lipoprotein A isn't really something on our radar in the UK, but it's another part of our lipid mix, and a bad one at that. Indeed, it's probably worse for us than LDL. What's particularly notable about lipoprotein A is that 90% of the level is genetically set, whereas LDL and that high sensitivity CRP can be more variable over time. So it makes it a really good marker to check when you're young to give you a reliable idea about your risk when you are older. This study then looked at the predictive value of these three markers for future cardiovascular disease, so in 30 years' time. The mean age of inclusion into the study was 55, 94% of the participants were Caucasian, and the median follow-up was 27 years. And just to reiterate, all of these patients were women. So the primary endpoint they were looking at was the first major cardiovascular event, so MI, stroke, cardiovascular death, for example. And then they compared levels of these three biomarkers singularly or in combination to see if there was a correlation with risk. The results showed then that all three markers predicted 30-year risk, with direct correlation between how high each was and increasing risk. They split the ranges for each biomarker into 5 levels, and then they showed that comparing the lowest level, the lowest quintile, to the highest one, LDL had an increased 30-year cardiovascular risk of around 36%, 33% increase for lipoprotein A, but the greatest risk was with those who had a raised high sensitivity CRP level. That was a 70% increase. They also looked at the cumulative incidence of major cardiovascular events for each of the three biomarkers. And if you looked at the highest quintile groups, then that cumulative incidence was 13% for LDL, pretty similar for lipoprotein A, and up to 16 or 17% for that high sensitivity CRP. Interestingly, all three biomarkers were independent contributors to overall risk. But in combination, their risk was greatest, and that cumulative incidence, if you were in the highest quintiles for all three of them, was around 30% incidence of cardiovascular disease at 30 years. That's pretty high, right? The authors concluded then that a single combined measure of high sensitivity CRP, LDL cholesterol, and lipoprotein A levels amongst initially healthy US women was predictive of incident cardiovascular events during a 30-year period. And they suggest that this data supports efforts to extend strategies for the primary prevention atherosclerotic events beyond the traditional 10-year estimates of risk. This, of course, has been looked at in women. It now needs to also be assessed in men too. And if they have a similar finding in that group, then you never know. Perhaps in a few years' time, we'll see all three of these biomarkers being part of the NHS health check. On to the BJGP then. This is in the current edition. It's titled Digitalised Primary Care in the UK, a qualitative study of the experiences of minoritized ethnic communities. And this is perhaps a warning about the unintended consequences of the actions that we as a healthcare system may take. Many practices have radically changed how patients access their services. This has often been out of necessity, with traditional systems just crumbling under the weight of demand, as we all know. My current practice now employs a total triage approach, using brief e-consults as the initial mechanism for contact. To my surprise, actually many patients have reported that they like this. They think that access is better. But then, of course, there's always concerns about the people that we don't see and who may have been left behind. This paper is not about searching our practice population, looking at ethnicity markers, and then comparing how these groups achieved access and the number of consultations before and after access mechanisms had been altered. This is qualitative work where the researchers, they sat down with 100 people classed as minoritized ethnic adults at 4 sites across the UK and asked them what they thought. The key reason for talking to these patients is that there already is existing racialized inequalities in access, and there's concern that primarily using digital channels, we're going to further exacerbate that. So the authors apparently adopted a critical realist intersectional approach. Now, you might know what that means. I didn't, but Google AI suggests that it is a framework for analyzing how social objects interact over time and how these interactions generate new objects. It can be used to theorize how oppressions and mechanisms interact between and within different levels of reality. Well, I do like my science fiction, but that still doesn't make any sense to me, and is another example of why AI probably isn't replacing humans anytime soon, not in general practice and presumably not in primary care research either then. What they actually did was conduct individual 1-hour interviews to explore the patients and their community's use of online services, particularly relating to general practice. The authors describe recurrent themes coming out. So one of the key ones was this implies a number of interacting factors such as limited access to digital devices, limited access to the internet itself, and limited digital literacy. And certain ethnic groups have disproportionate levels of poverty, which then obviously drives those problems even further. Lack of linguistic sensitivity about health services was another big issue. And I can hear all those people in the background, not necessarily you guys who are listening, but that's that age-old thing about, you should learn English when you're coming to this country. But as these interviews show, not everyone is afforded that opportunity when they move to the UK. The third major factor was our use of tools that are designed around white populations. A Black African participant gave the example where he'd been asked, does he have any red patches? And as he pointed out, he wouldn't be able to see this and it would probably look very different on his skin. The authors concluded that the rapid digitalization of primary care services is replicating and potentially exacerbating barriers to using these services amongst minoritized ethnic communities, a finding that merits urgent attention by practitioners and policy makers. And they highlight the need for more anti-racist, culturally competent, user-friendly access avenues to ensure the effective delivery of digital-first primary care services. Perhaps one for us and for policymakers to reflect on. So I hope you've enjoyed the podcast today. We'll be back in a week's time with another one of our special interviews, this time with Dr Katie Bramall-Stainer, so chair of the GPC in England. She is extremely interesting to listen to, and if you're wondering how collective action is having an impact, then you want to listen to this podcast. And don't forget, you can always get in touch. You can email hottopics@nbmedical.com. You can find us on X and Facebook and probably several other places that I've never even heard of before because I'm too much of a dinosaur these days. Have a good weekend, everyone. We'll see you next time. Bye-bye.